So we're going to go over the questions first, and while I think of it, just to while Aiden's already got it up there, so let me go ahead and go over those, then I'll come back to what I was going to say. So so begin with from the questions is the first question was endometriosis is due to a proliferation of what type of tissue? And the correct answer is uterine. So endometriosis, the endometrium is basically the uterine lining, so the tissue that's similar to the uterine lining. So the correct answer is B. Question 2, DHE can be converted to either testosterone or estrogen. And remember, we talked about several of those compounds, and specifically we did talk about DHEA. So the correct answer, actually that correct answer is, that should have been, correct answer should be A. So Aiden, if you would change that or correct it on the key, that would be it. So DHA can be converted to either testosterone or it can be converted to an estrogen. So the correct answer should have been A. Question number 3, danazol is used for the treatment of prostate cancer, osteoporosis, endometriosis, oral contraceptive, and the correct answer here is C. It's one of the first-line agents that we used to use, although we are seeing some more GnRHs being used for that. And then finally, leuprolide is an analog of gonadotropin-releasing hormone, thyroid-stimulating hormone, growth hormone, or somatotropin, and the correct answer is gonadotropin-releasing hormone, what we talked about right before we broke for lunch. Okay, so the only thing to be aware of is that I miskeyed question number 2. So DHEA can be either converted to testosterone or estrogen. Typically, it's going to be converted in most people to the testosterone or the androgen type, but there is some individuals that it will go to estrogen. Okay, all right, let's see. All right, I'm just double checking to see. I thought I had somebody else that had put something on the chat board. Okay. All right, so let's pick up where we were going from or talking about. And again, what I'm going to do is my plans are we will cover the rest of the hypothalamic hormones, and then we will cover the basically the movement disorders. The last set of slides, which it is highly unlikely we would get to cover all of them. If not, we may get to cover some of those. If we don't, Najib, these were you talking about these questions I just asked about, or that we just went over? These were the in-class questions at the end of the last period of the morning session. So like I said, what we're going to do is the FSH, we're going to cover the rest of the hypothalamic pituitary hormones. We're going to talk about the movement disorders, and then we will hit some highlights on the antibiotics. And there may be one or two things that I will focus on with the antibiotics that I will specifically tell you that may be on the test. And so unless I specifically tell you that's, when we get to that antimicrobial handout, I will, we'll talk about what would be on the test so that you may not have to spend a lot of time on those, okay? All right, so one of the things we see is that, let's talk about FSH, follicle stimulating hormone. And what we see is that over 50% of either the men or women that have hypogonadotropic hypogonadism can become fertile after treatment to correct this. So what's happening with hypogonadism, we have a reduction in the in basically testosterone and estrogen, depending on if it's male or female. And so that's the hypogonadism. And we also have a deficiency of hypogonadotropic hormones. So in this case, basically, we've got a deficiency of the testosterone and or estrogen, and we have a deficiency of FSH and LH. So that it makes sense that if we treat these individuals by replacing, for example, FSH, that would be affected. So it works pretty well. The biggest concern we see some indications with women when we give them FSH that they may develop ovarian enlargement. That typically is going to be an uncomplication. So the ovaries sort of increase in size. However, we don't see that there's a real problem, and typically that resolves spontaneously. So we may see an increase in the size of the ovaries, but they basically then sort of resolve. what our biggest concern is hyperstimulation syndrome. And with hyperstimulation syndrome, what happens is the ovaries enlarge, and this becomes a more of a concern. So we get ovarian enlargement. We start getting ascites, which, if you remember with the ascites, that is abdominal edema. So in the abdominal cavity, they start generating there, or they get a lot of fluid there. They may develop what is called hydrothorax, which is fluid in the chest cavity. And what happens as a result is, what's happening here is the fluid is leaving the vascular system and going into the tissues or to the interstitial spaces. And so part of that is going into the abdomen, some of it's going into the chest. When it leaves the vascular compartment, what's going to happen is the volume drops. And so the individuals basically go into hypovolemia. So what we've gotten is an overstimulation, as the name implies, hyperstimulation by FSH. And the biggest concern when this is occurring, we start getting fluid in the abdomen and in the chest, and the blood pressure starts dropping because they become hypovolemic. That's what we have to be careful for. This can actually, they can go into shock. So that is a concern there. That is, it's a rare syndrome, but they need to be care of it. We do see some instances where occasionally you can get some ovarian cysts that may rupture. There may be some thromboembolism. We have to be aware of that. And in males, we may get gynecomastia, where we also get an increase in frequency of multiple births. So it can, almost go to the other end of the spectrum. So what we see is that, so FSH we can give. The other gonadotropin that we may sometimes be deficient in hypogonadotropic hypogonadism is LH, luteinizing hormone. So if you remember, the luteinizing hormone will actually act on the Leydig cells, and that's in males, which are in the testes, and that will actually stimulate testosterone. And in women, the luteinizing hormone and with follicle stimulating hormone actually is going to stimulate the development of the follicle in women, and then basically that is going to induce ovulation. This can also stimulate the corpus luteum, which is a source of progesterone and also androgens. And so, so this is, this can be used to increase both testosterone production in males, and it can be used to stimulate ovulation in females. The issue is we don't have luteinizing hormone preparation. We don't have the actual luteinizing hormone. It's not available commercially. But what we see is human chorionic gonadotropin, which is called HCG. It is a gonadotropin, and it is very similar in structure, and actually it is so close that you can actually use this as a substitute for luteinizing hormone. So I tend to ask a question later on, possibly later on in the week, really is, what do we use as a substitute for LH, or, LH is used to stimulate this, some sort of question along those lines. So I'd maybe mark that slide. It just seems to be one of the questions that I usually like. So, so we use HCG, human chorionic gonadotropin, and where HCG is actually produced is by the placenta. It's actually produced by the placenta, then it's excreted in the urine, and basically it can be extracted and concentrated. So what HCG does, it does the same thing that LH does. The structure is it's so similar that there's no problem with using it. So when you give HCG, you're going to get an increase in production of progesterone and testosterone. Okay. So we can use it sometimes for diagnostic purposes to determine if there's cryptorchidism. Generally, if it's cryptorchidism, we know that it's undescended testes, because from physical exam, the testes will not be there. We can do ultrasound and see where it's at. But we may use it to diagnose hypogonadal states. It is used to induce ovulation and also used for in vitro fertilization. And it's also used sometimes in males to promote spermatogenesis. The side effects are headaches may be commonly caused. One of the things you should be aware of is that it can cause depression. We do see potentially some edema that occurs in children. We may see it in precocious puberty, and in males, we may see gynecomastia. Okay, so big thing is we can use HCG instead of LH because we don't have an LH semen. Prolactin is very similar in structure to growth hormone. And remember, prolactin is primarily responsible for lactation. So we don't have any commercial preparations of prolactin available. So what we're going to use instead is dopamine agonist. And dopamine agonist can stimulate the pituitary gland and work that way. So basically what happens is that if we have dopamine released from the hypothalamus, that basically inhibits prolactin release from the anterior pituitary. So what we can do is we can give an agonist, and some of the agonists that we can use is one is an ergo derivative. These ergotamines, they're used sometimes for the for migraine headaches. They have a pretty high affinity for dopamine 2 receptors, and we've got things like bromocriptine, carbergoline, and pergolide. Now, the problem with ergo derivatives are they are pretty strong vasoconstrictors. So one of the things we're worried about when we use these ergot derivatives is they can cause severe vasoconstriction, may raise up blood pressure. Quinagolide is a non-ergo, so as a result, it has a little bit of preference because of, especially if you have somebody that is got high blood pressure or you're concerned about raising their pressure. So the way that these dopamine agonists decrease prolactin levels is they decrease dopamine turnover in the tuberoinfundibular neurons up in the arcuate nucleus, and that increases hypothalamic dopamine. So if you go back, is that basically the dopamine is released from the hypothalamus. What we're going to do is we're going to increase the hypothalamic dopamine, and we're going to also have a direct stimulation of pituitary to get growth hormone release. So what we use this for is to basically antagonize the prolactin. So if we have prolactin secreting adenomas, we're getting too much prolactin secreted, then these dopamine levels are basically going to inhibit that. When people have amenorrhea or galactorrhea, where they're producing out, having difficulty with their periods, and prolactin can suppress that. Galactorrhea basically, is excessive, and we see this a lot with women that may be taking antipsychotics. So the dopamine agonists, typically the antipsychotics are blocking dopamine receptors, so the dopamine agonist would reverse that. They do use these sometimes when women are breastfeeding or that are not going to breastfeed. The breast can become engorged, and that can be very painful. The other thing is that if the breasts become engorged and there's milk stasis, that can set up for some infection that occurs. We see dopamine also these agonists can be used for acromegaly. We'll talk about the dopamine agonist being used in Parkinson's in a little bit. And also it's used for restless leg syndrome, which we'll talk about that a little bit too when we talk about movement disorders. So typically the biggest thing we worry about is on a short-term basis, patients have complained of nausea, headache, fatigue, orthostatic hypotension, and these are fairly easy to manage with. We do have some patients that these are bothersome enough where they won't be compliant. But one of the things, the two biggest concerns we have with these dopamine agonists are, one is we can have some psychiatric manifestations. So think about it, when we're dealing with psychosis and things like that, we're actually using drugs to decrease dopamine. So if we give a dopamine agonist, that is can potentially activate these dopamine pathways. And we will go into this in detail when we talk about schizophrenia, about the different pathways and the dopamine serotonin interactions. So one of the things is that these dopamine agonists can induce psychiatric manifestations, and sometimes this may take months for these to resolve. So that's a concern. Another thing, especially with these ergo derivatives that I told you can cause severe vasoconstriction, we can get what is called cold-induced peripheral digital vasospasm. So what's happening here is basically the blood vessels in the fingers, toes, the ears, the nose, but it seems to be more prominent in the toes and the fingers, is basically when it's cold out, and if they're exposed to cold temperature, these blood vessels vasoconstrict, and it becomes very painful. Also, not only does it become painful, but it may be very difficult for these individuals to perform certain jobs if they're writing, painting, or using, the fine motor skills of their hands. This can impair their job ability. All right, so let's move to another hormone, vasopressin. We touched on a little bit earlier when we talked about diabetes, I think last week. So vasopressin is known as antidiuretic hormone, or ADH. It's released by the posterior pituitary, and it responds to if blood pressure starts dropping, or if what we call plasma tonicity, so changes in sodium, may occur. So the problem is basically if the body detects that your blood pressure is dropping, or your sodium is getting too concentrated, what it does is it releases vasopressin, which gets you to retain fluid. So it's an antidiuretic. And so what happens is that by retaining fluid, that helps your blood pressure stay up and keeps it from dropping. The other thing is that when your sodium levels are so concentrated, then by retaining fluid, what that's going to do is it's going to dilute out the sodium. But if we have a deficiency of vasopressin, we get a different type of diabetes. So we have talked about treatment of diabetes mellitus, which is, we talked about insulin-dependent diabetes. Well, with vasopressin, we get diabetes insipidus, okay? So this is sometimes referred to as water diabetes, okay? So what we have is we have vasopressin receptors. We have vasopressin 1 receptors. Those are on the smooth muscle cells, and they cause vasoconstriction. That's the term vasopressin, which is referring to vascular pressor. And we also have V2 receptors, vasopressin 2 receptors, on the renal tubule cells, and when they're stimulated, they tend to produce an antidiuretic effect. So we get an antidiuresis, which means we don't go to the bathroom, we retain fluid. When people drink alcohol, one of the reasons they have to urinate is, well, first of all, they're taking in fluid, but another thing that happens is that alcohol can inhibit vasopressin. So it inhibits the antidiuretic hormone, which means that basically it makes you want to go to the bathroom more frequently. So what we have is we do have a synthetic aqueous form of vasopressin, okay? The problem is it's very short acting. We have to give it parenterally. So that limits its usefulness for, any longer long-term control or any, other than having them in the hospital, we have to use the vasopressin. However, we do have an analog of vasopressin. Remember, ADH stands for antidiuretic hormone, which is the same thing as vasopressin. We do have a drug called desmopressin acetate, okay? Desmopressin acetate actually is a little bit better than vasopressin. It's sort of like, acetylcholine. We have drugs that are better than acetylcholine. So the reason desmopressin is actually a little bit better than trying to use the actual vasopressin, other than the fact that it's a shorter acting drug, is what we find is that the desmopressin, it doesn't stimulate the V1 activity. So it doesn't appear to have very, very much vasopressin 1 receptor activity. In fact, it's estimated that its antidiuretic action, which is based upon vasopressin 2 receptors, when compared to the vasopressor activity, which is based upon vasopressin 1 activity, is that we see that compared to vasopressin, it's about 4,000-fold greater. It's 4,000-fold greater as an antidiuretic than it is pressor agent. So what we're able to do is that one of the problems we have in people with having diabetes insipidus, they are putting out an awful lot of urine. I mean, we're talking about liters per day of urine, okay? One of the things is that when you are putting out that much urine, is that you're going to the bathroom an awful lot. You're drinking an awful lot. So one of the things is these people keep, if they're not being treated, in addition to the concerns of them putting out all this urine and so forth, one of the things that happens is they're getting up all hours of the night going to the bathroom. Okay. What they used to do is basically sometimes put diapers on them or sometimes put, like a catheter in them to keep them from having to, get up at all during the hours. So what they do is they give this at bedtime. And when they do, what it does is it reduces the nocturnal enuresis. Okay. So this one is the preferred treatment. We couldn't use this for, with regard to the, if we use vasopressin, it's just we're going to have them, literally, we got to pretty much give them a infusion. And the other thing is with vasopressin, we got to worry about it raising their blood pressure. So this desmopressin is actually the preferred drug to use for treatment of patients with diabetes insipidus, mainly because no vasoconstriction or very, very minimal vasoconstriction and strong antidiuretic hormone. The side effects, headache, nausea, and vomiting. We do see occasionally some agitation. So if we have a patient with diabetes insipidus on desmopressin, or even, even for some chance so there are some people that start off with vasopressin. The bottom line is that if it starts occurring after this, then it may be the drug induced. We can see some hyponatremic convulsions. So there is a potential for hyponatremia where they are losing too much sodium. And so this is a possibility that can occur. But with vasopressin, one of the big things is we just worried too much about vasoconstriction. We don't have to worry about that with desmopressin. The vasoconstriction, a lot of times we would not use it in coronary artery patients because they already have reduced coronary flow and severe constriction could precipitate an infarction. Same thing with stroke people. All right. So that's sort of the hormones that we've talked about. We're going to move to a couple of the posterior pituitary hormones. And one of the reasons I'm going to cover these, you guys are not going to be treating pregnant women during delivery, but you need to know about some. And so we have uterine stimulants and we have uterine agents that are going to slow or that are basically going to suppress the uterus. So these uterine stimulants you may need to be aware of because they have been used as abortificants. So they've been used to induce abortion in the first half of pregnancy. Since they're uterine stimulants, they have been used when women have been in labor and are not seeming to progress. So we use it to induce or augment labor. Oxytocin is a good example of this. And the other thing that we do is after birth, we use these uterine stimulants because as soon as they give birth, by using these uterine stimulants, the uterus will contract, and when it contracts, it squeezes down on the blood vessels, and so it can decrease postpartum bleeding. So one of the things, the uterus is sort of a unique situation because its pharmacology changes. Its pharmacology is different when the uterus is pregnant versus when it's not pregnant. The pharmacology is different when we're in early pregnancy versus late pregnancy. So we find that picking the right agent, some agents will work at certain times in women, other times it won't. So when we go to, there's a lot of drugs that can be induced, that can induce motility of the uterus, but a lot of them are very nonspecific. They stimulate a lot of smooth muscles, and a lot of them have some pretty severe side effects. So we're very limited to what we actually use. Probably the most common we use to stimulate uterine contractions is oxytocin. And one of the things is, oxytocin, there's a lot of research involving with some of the psychological and central actions of oxytocin. We've used prostaglandins, both prostaglandin E and prostaglandin F. We've used those ergoalkaloids. We just talked about those. Those are ergotamines. And we've used antiprogestants. Main thing I want you to be aware of is primarily oxytocin, because you're not going to be prescribing this per se, but you may see some uses of it down the road. Oxytocin is probably considered the most specific and potent stimulant we have. Okay. People say that it produces uterine contractions the same as normal labor. When you talk to women that have been given oxytocin, they will tell you that contractions without the oxytocin are fairly manageable, but many of them tell you that you move up to the Richter scale when you get oxytocin. So when to say that they're the same as normal, physiologically they are the same as normal because we're using a substance that the body is producing to do that. However, many women will tell you that the oxytocin-induced contractions seem to be more intense. So we do use oxytocin to induce labor. We use it sometimes when we need to tweak because the labor is not moving, progressing like we would anticipate. Now, interestingly, during early parts of pregnancy, early gestation, oxytocin doesn't have very much of effect. And the reason for that is because that the uterus does not have a lot of oxytocin receptors. What you see is as pregnancy progresses and we move toward late gestation, the number of oxytocin receptors increase. So it's sort of a physiological component is early in pregnancy, we're not going to really need oxytocin, but late in pregnancy, when we're going to actually have labor, then we're going to need it. So the body will upregulate receptors for those. It has to be given parenterally, given by an IV drip. And what we find is that it will stimulate contractions, but there's a thing about the cervix, they refer to it as ripening of the cervix. So the cervix has to be prepared to dilate, and they can use some certain things to, quote, ripen the cervix. They can put some prostaglandin E2 on, there's some gel that can be applied to the cervix. Sometimes they may use a Foley catheter to sort of stimulate the cervix, or they can use some of what they call laminaria tents. I'm not exactly sure. It's been a long time since I've looked up what laminaria tents are, but these are actually means of stimulating the cervix to get prepared to dilate. What you worry about with oxytocin is that you can get hyperstimulation, okay? So what happens is if contractions start occurring sooner than every 2 minutes, that's considered hyperstimulation, or you start having these prolonged tectonic contractions. So what happens is the muscle contracts and stays contracted for a while. Our concern during this hyperstimulation, one is the cervix contracting can press down on the fetus and actually produce bradycardia of the fetus, and so it can distress the fetus if it's too strong. The other thing is that hyperstimulation is pretty painful. The nice thing about oxytocin is typically, most of the times, by simply stopping the infusion, is the effects of oxytocin will absolve. So that's what we do. The other thing we have to be careful about is that if you try to use oxytocin very early in pregnancy, and we did see people try to use oxytocin sometimes to induce abortion, that can cause vasopressin to be stimulated, and that can lead to basically a water toxicity, which is where the body just retains fluid. You're not urinating, and what it does is dilutes your sodium out, and then you can go into severe hyponatremia, which can result in convulsions. Another thing is that there are instances where that too much oxytocin has many times there's comorbidity, such as that there's a weak uterus or something, and so the contractions have been severe enough to cause rupture. Prostaglandins can be used. Prostaglandins, basically the uterus, compared to oxytocin, uterus is always responsive to prostaglandins, and a lot of time they will use prostaglandins coupled with RU486 to induce early abortion. Used late in pregnancy, they will use it to ripen the cervix, as I said a moment ago, and to actually stimulate contractions. Typically, we're going to see PGE2 and PGF2 alpha. Typically these one of the things is that some of the receptors can induce relaxation, but mainly we get contractions, so these prostaglandins will do it. Sometimes prostaglandins have been administered locally, so directly onto the into the cervix and uterus wall to actually terminate pregnancy, and that's been done after 18 weeks of gestation. Strong contractions, uterine hypertonus, which means it's sort of in a contracted state, can cause rupture. Prostaglandins, even though they're given, can be given topically. If there's any systemic, they can get some GI problems, bronchospasm, so it's a concern with somebody that may have pulmonary problems. These frequently, or these are, when we see these other problems, it's generally with systemic. They are very, very, very rare if it's given locally. So that's one of the reasons why they do that, is the local administration at the doses they use should not produce these actions. The ergoalkaloids, basically, they're more, they produce a strong contraction of the uterus, the myometrial, which is part of the uterus. The endometrium is the inside of the uterus. Myometrium is the muscle layer of the uterus. So these drugs really do not work good for labor, to induce labor. Their oxytocin is much, much better. But what these are is, because these tend to produce strong, constant contractions, these are used after birth to basically to treat postpartum hemorrhage. So after birth, there's a lot of bleeding that occurs, and typically what's going to happen is the uterus should contract down, and that contraction actually squeezes the blood vessels and should stop bleeding. If it doesn't occur on its own, they may use prostaglandins to do that. One of the problems here is that you've got to be careful about, these drugs. The ergoalkaloids can cause blood pressure to go up and systemically, and you can get hypertension. We've already talked about RU46. That one is typically, the uterus becomes quiescent due to the progesterone. And so we see this used for early pregnancy. Late pregnancy, we do see that it can be used to induce labor, but you got to give it with a prostaglandin. Now, we talked about uterine contractors or uterine stimulants. Let's go to the other end of the spectrum, which are the uterine relaxants, okay? So these we use to try to either prevent or stop preterm labor, okay? Sometimes we use it, for example, when we've overstimulated the uterus using some of these stimulants, and we can use these relaxants to sort of offset that. And the other thing is that we can see physicians use this to relax the uterus so that they can maybe do some manipulations of the fetus intrauterine, like if they're trying to position the baby or something like that. These uterine relaxants, the other thing we see them for is when women have dysmenorrhea, which is very painful periods, and we get the strong contractions, then basically these uterine relaxants can sort of help with that. So you may see individuals being used with this uterine relaxants or having on these. How effective they are, there's pros and cons. There's some people say they are very effective. There's others that say they're completely ineffective. They were actually developed to try to stop premature labor. And so the term of stopping uterine contractions is called tocolysis. And so these drugs are referred to as tocolytic agents. They're designed to relax the uterus, okay? If there's a concern, we see, especially between weeks 20 and 35, these often may be administered if it looks like there's going to be premature delivery. The thing is, these uterine relaxants really are not specific for the uterine bed. So wherever you got smooth muscle, there's a good chance that these drugs can have the same effect. And the biggest thing is that because we have a lot of smooth muscle in the cardiovascular system, is the cardiovascular side effects is really what limits their usefulness. One of the big things we see is if you relax too much, you're going to drop blood pressure. So we have beta agonists, and one of the notice some of these drugs are these beta agonists would also be used for potentially be used for asthma or pulmonary problems. Typically, we see retidrine and terbutaline. Terbutaline is frequently used for COPD, and these drugs they're beta 2 agonists, and basically remember beta 2 receptors Beta 2 in the bronchioles cause, when you stimulate them, they cause bronchial relaxation. In the uterus, the beta 2 receptors will cause the uterus to relax. At higher dosages, they can stimulate other beta receptors like the beta 1 receptors. So we have a concern about other beta 2 receptors as well as beta 1. The beta 1 receptor would be the heart, so stimulation of a beta 1 receptor may increase the force of contraction and the rate of contraction. And the biggest concern we have is pushing the heart too much, or it can also relax the blood vessels so that the blood pressure drops. So vasodilation and hypotension, that's beta 2. Maternal tachycardia, that's beta 1. So stimulation of the beta 1 receptors can stimulate it. Also, if you drop blood pressure too much, it may be a reflex stimulation. We also see that both hyperglycemia hyperglycemia has occurred. That's a beta action. We can see some hypokalemia, so their potassium levels drop. And when the fetus, our biggest concern is the fetal tachycardia, the heart's beating too fast, and the fetus develops hyperglycemia. The other drugs that have been used, we do use an NSAID, in particular, indomethacin is one that's been frequently used, but any of the NSAIDs may be effective. And these NSAIDs may also be used to treat, these prostaglandin synthesis inhibitors may be used to treat dysmenorrhea. And our biggest thing is, when we're using it, is probably concern for GI bleeding, as we talked about yesterday. But you can also get some bone marrow suppression. One of the big problems we have with these prostaglandin synthesis inhibitors is in the fetus. So if we have a pregnant woman and we give them this, and the ductus arteriosus is the opening. So when the fetus is in the womb, the blood is not circulating through the fetus lungs because the fetus is getting all the oxygen from the mother's blood. So there is an opening that bypasses the lungs in the heart, and this is called the ductus arteriosus. So one of the things is, when the baby is born, the oxygen going in initiates a stimulus for that ductus arteriosus to start closing. And when it closes, then we're pumping blood through the baby's lungs. Okay, so that happens at births. And so what we can see is, if this is given to the mother, these prostaglandin synthesis inhibitors, one of the things that can happen is that ductus arteriosus may start closing while still in utero. So we may see some, or it may prevent the ducts. Sometimes it can prevent the it'll leave the ductus arteriosus, may still stay there and it doesn't close. So that's the concern with these drugs. All right, Eddie, I'm going to double check my fittings here just to make sure. I think they're still there, but sometimes there's a little bit of just a very little play, and sometimes that can that. So I just, let me know if that gets worse, but I just tightened it. So the most commonly used tocolytic agent is going to be that is a drug called magnesium sulfate. It's really not a drug, it's sort of a solution. We don't really know how mag sulfate works. What we do see is that it probably acts sort of a calcium antagonist. It may compete with calcium. So mag sulfate is frequently used to to offset contractions or to decrease them. We see people, it's sort of a depressant. The skin flushing, we see some heart rate some heart palpitations. Reflexes seem to be depressed, as is respiratory. The fetus tends to relax, and typically we don't get CNS depression, but we do get some depression with the in the mom. And there's currently some work on trying to develop an oxytocin antagonist. They've been looking at modified or analogs of oxytocin. The idea is that it would be very specific for oxytocin and blocking the oxytocin. And the ones that they've been looking at don't appear to cross the placenta, which would be good for the fetus. but they, these are still under clinical development. So this is sort of the thing that they're thinking about in the future. All right. So that is, we finished the hypothalamics and pituitary um, drugs. And so we're going to move to the movement disorders. And let's do this. Let's go ahead and take our big afternoon break right now. We'll come back at 5 after the hour. And when we come back at 5 after the hour, I'm going to have the new slides loaded, which should be slide set 4, which is your, should be a treatment of movement disorders. Okay? So I will see you guys back at 5 after the hour. Go back and we're going to start on this last group of slides. What we'll do is we will go for a little bit, and then we'll let Aiden do attendance and the quiz, and then you'll have the post-test at the end. But, let's start talking these slides that we have here. I think these are an important group of drugs for you guys to be aware of. The reason for that is because one of the groups of drugs that you will prescribe, which will be the antipsychotic drugs, have a propensity for producing these extrapyramidals. So it's important that not only you know about the drugs that can cause this, but also the various modes of treatment. So these abnormal movements, many of these, here's a key point that shows up a lot of times, is that many of the movement disorders are usually associated with the with changes in the basal ganglia, okay? And in particular, dopaminergic disturbances there. So the basal ganglia is going to be an important point. We will go into this in much more detail when we talk about the drugs used, the antipsychotic drugs. We'll revisit this. The individual symptoms that we see generally cannot be related to a specific site. So what we do is we look at primarily, we know that certain disease states that are not drug-induced, that basically they will develop they can develop these changes, like, for example, Parkinsonism. We know about it. We know where the changes occur, and we see very similar symptoms and everything that occur when we use drugs that basically interfere with the transmitters. So we've seen it from a standpoint of the pathology of the disease that produces similar movement actions. We also see it from the standpoint of the situation where that certain drugs interact with these systems and produce very similar actions. So let's start with Parkinsonism and just review a little bit, is that it is usually a progressive disease. So we're going to talk about treating Parkinson's, today is one of the things. So this is usually a progressive disease that leads to disability. I've had 3 or 4 of my friends and colleagues that have passed on due to Parkinsonism. We do know that from a pathophysiological state, that what we do know is that basically that dopamine in the basal ganglia is reduced. So we have a situation where we have hypodopaminergia. So the amount of dopamine that is present, and we know where the area is. You cannot diagnose Parkinsonism. We diagnose it by symptoms, but it can't be confirmed until autopsy. So typically what's happening is that there's dopaminergic neurons that are normally inhibiting the output of GABAergic cells that are in the corpus striatum. These are lost. So from a standpoint of how do we treat Parkinsonism, we've got to, the ultimate thing is going to be that we've got to elevate the dopamine in those areas, okay? So one way we treat them is to actually increase the amount of dopamine in those areas. So we've got a low dopamine area, a low dopamine situation. By elevating the dopamine levels, then the idea would be that we would offset what's causing the disease. So that's what we're going to do, okay? Another thing is that we've discovered there's a balance between the cholinergic system and the dopaminergic influence on the basal ganglia. So typically what we're seeing is that dopaminergic concentrations are going down, but another way we may treat it is that even though the dopaminergic concentrations go down, what we may want to do is try to offset the imbalance between acetylcholine and dopamine. So those are our two, if you will, therapeutic strategies we have. Now, we do know the other thing we have to look at when we're treating these diseases, the other thing that we have to look at is that we have to look at, when we're doing the assessment and everything, is we got to find out potentially what's causing the Parkinsonism. So one of the things that we need to do is to find out, is that person potentially taking a drug that could be inducing the Parkinsonism? And so from that standpoint, one of the things that we might need to do is it might be that we need to lower the dose of the drug or remove the drug from their system and replace it with something else. So one of the things is dopamine antagonist, and again, the antipsychotics are what you will prescribe, and is one of the largest causes of drug-induced Parkinsonism. When we talk about the antipsychotics, one thing to realize is years ago, the drugs that we were using, those dopamine antagonists, they were very strong dopamine antagonists, and almost all of the drugs produce some form of extrapyramidal symptoms in Parkinsonism. The drugs we have today, because they have a serotonin component, they basically are dopamine antagonist and serotonin antagonist. So the new atypical drugs, because of that serotonin component, they have less chance of causing that. And actually, we will go into how that actually occurs by looking at the different pathways in the advanced pharmacology course. But for right now, what I want you to do is just understand that dopamine antagonists that get into the brain have a potential to cause Parkinsonism. We also have drugs. There's drugs that are various designer drugs that are on the street. There's a drug called MPTP. Sometimes people making street drugs, ecstasies, and some of the club drugs, their synthesis leaves some intermediates in there that may be particularly virulent as far as attacking the dopamine. So sometimes these designer drugs that are on the street may actually produce a permanent destruction of the dopamine nigrostriatal neurons, and those are usually not irreversible, okay? So drugs that induce Parkinsonism typically are going to either be dopamine antagonists or are going to destroy the dopaminergic nigrostriatal neurons, okay? Now, if you look at it, we look at drugs that are used to treat Parkinsonism. Many of them are involved in either restoring. So, for example, L-DOPA, levodopa, is going to restore the dopamine. Dopamine agonists can be used. COMT inhibitors, catecholomethyltransferase inhibitors, will inhibit the breakdown of dopamine. Monoamine oxidase inhibitors will inhibit the breakdown of dopamine. So the net effect, if you inhibit the breakdown of the dopamine, then it's going to stay around longer and concentrations are elevated. But we also have drugs like amantadine and acetylcholine antagonists, which will help restore that cholinergic dopaminergic balance. So we're going to start off with one of the mainstays of therapy, which is L-DOPA. All right. So first of all, we want to restore dopamine and in the brain. And so one of the things that's going to be important, since we're looking at a progressive disease and we're going to be treating throughout the disease, one of the things is we've got to have a drug that will basically move across the blood-brain barrier. Dopamine we can't give for two reasons. One of the things that happens with dopamine is that basically dopamine will not cross the blood-brain barrier. So we can't give dopamine and have it get into the brain. Another thing is just simply is we gave dopamine orally. Catecholamines like dopamine would be destroyed by the various enzymatic systems and actually in the stomach. So if we gave dopamine peripherally, like orally, even an injection, not going to have any effect because there's not going to be enough that would even get into the brain to produce an effect. So what we've done is one of the approaches has been, let's take a precursor of dopamine, L-DOPA, and the L-DOPA will cross the blood-brain barrier, and then it uses the body's normal catecholamine synthesis mechanisms to pretty much convert L-DOPA to dopamine. So the advantage of L-DOPA over dopamine is that the L-DOPA will go across the blood-brain barrier and can increase the levels of dopamine in the brain. So what we see is primarily once we increase the dopamine levels, the main thing is it usually comes down to is the D2 receptor seems to be the most important. We may see that both D1 and D2 is necessary to get maximal benefit, but in general, we're looking for primarily the dopamine 2 receptor stimulation. So we want, by increasing dopamine, dopamine is going to stimulate both dopamine 1 and dopamine 2 receptors. So when we give L-DOPA, probably only about 1 to 3% of it will enter the brain. So in order to get enough of it in the brain, if we were given L-DOPA, we're going to have to give really large doses. The problem here is by giving large doses of L-DOPA, we're wanting to get it in the brain, but when the L-DOPA is given, it's given peripherally. And so one of the major issues that we run into is that we can get peripheral, the L-DOPA that's in the periphery is going to be converted to dopamine and actually maybe even converted to norepinephrine. And so we can get some peripheral side effects. We can get increases in blood pressure and things like that. So the bottom line is that L-DOPA is to get enough dopamine formed in the brain, we have to give a fairly large dose. So how do we get around that? Well, we get around it by using a concomitantly using a drug called carbidopa. Okay, so what carbidopa does, carbidopa is actually does not cross the blood-brain barrier. Okay, so carbidopa is going to stay out in the periphery, but since it doesn't penetrate the blood-brain barrier, it's not going to have any effect on the dopamine levels up in the brain. But what it does do is carbidopa actually inhibits dopa decarboxylase. And dopa decarboxylase is the enzyme that converts L-DOPA to dopamine. Okay? So what that does is the carbidopa basically prevents the L-DOPA from being converted to dopamine in the periphery. And what that means is that typically we don't have to, if we use L-DOPA alone, we have to use a lot of it. But by using carbidopa, it reduces the dosage that we give daily by about 75%. So what you're doing is you're preventing the L-DOPA from, although it crosses the blood-brain barrier, when you give it periphery, a lot of it's going to be used to make dopamine, and then dopamine converts to norepinephrine in the periphery. So by inhibiting the conversion of L-DOPA to dopamine in the periphery, more of the L-DOPA gets up into the brain. Okay, so it's a nice strategy that we see to get a high concentration. Unfortunately, what we find is L-DOPA works pretty good for a few years, and then what we see is that we typically, as we continue to use it, we have to reduce the daily dose because ultimately we start getting some side effects. We may start, what may be occurring is that what's happening is because we're creating it, we may actually develop a denervation or drug-induced supersensitivity. Since we're getting a lot of dopamine converted, then the body basically may suppress that, and then we may see that we start getting supersensitivity, so that when the L-DOPA is given, basically what's going to happen is we get greater stimulation. In some individuals, as time goes on, they become less responsive. Many times we think that is probably due to the progressive degeneration, and so that the nerve terminals, basically the amount of nerve terminals that the L-DOPA could enter, basically degenerate. So that may be why we get a less responsivity as we go over time. So what we find is L-DOPA doesn't stop the progression of the disease, but what it does do is it can we started early in the disease process, we find that it lowers the mortality rate. So what it does is it prolongs life for a while. So there seems to be advantage of using L-DOPA. Now, again, the best way to give it is going to be in combination. So you can do it one of two ways. One of the things that we can do is we can give L-DOPA and carbidopa separately, but we also have a drug called Sinemet. And what Sinemet has is that it's a fixed proportion of dopa and of L-DOPA and carbidopa. So you've got in one concentration, it's 1 part L-DOPA and 10 parts carbidopa. Another preparation, it's 1 part L-DOPA and 4 parts carbidopa. Sinemet actually has been shown in some patients to completely ameliorate all the clinical effects of the disease. And we see that that can occur. That's not always the case, but it can. The one thing that seems to be pretty responsive to it is the bradykinesia. The carbidopa, the bradykinesia is the slow ratcheting movements that occurs with this. And we see it's estimated about a third of the patients respond pretty well to the Sinemet. But again, it's limited. The disease continues to progress. The other thing is, like all drugs, there are certain adverse effects. What we see, and again, this is a benefit-risk assessment because the disease is progressing and the quality of life is so bad with this, is that typically what we're going to see is that we will see people use this, but there is a pretty high incidence of side effects. Using L-DOPA by itself, we see a high percentage of patients will complain of loss of appetite, nausea and vomiting. But what we see is that when it's combined with carbidopa, that helps pretty well. What we have to be careful is with this nausea and vomiting. Early on, people would say, "Oh, they're getting nauseous. Let's give them an antiemetic." A lot of the antiemetics like Phenergan and stuff like that we used to use actually were actually dopamine, interfered with the dopamine system. So by giving them an antiemetic, it actually reduced the therapeutic effects of L-DOPA. And not only did it reduce the effects, but sometimes it would even make the symptoms or exacerbate the symptoms of Parkinsonism even more so. One of the big concerns we have, and especially without the carbidopa, was cardiovascular actions. What we saw is that without using carbidopa, we saw an increased incidence of arrhythmias. That was probably due to the formation of norepinephrine and potentially epinephrine. Many times individuals would, even with the L-DOPA, they may have some hypotension, postural hypotension. That will tend to go away over time. But we also had to be careful because if they're on a monoamine oxidase inhibitor, we could get hypertension because we would get too much catecholamines formed. But the other thing we have to be careful with is if they're taking sympathomimetics. Does anybody remember sympathomimetics? What are some drugs that are sympathomimetics? Kara, I checked on that. I don't have anything pushing on the mic. It's pretty clear. It must just be some other interference from somewhere. In fact, the mic's on a stand, so it's there. But I'm going to wiggle the cords just a little bit. Does anybody hear anything with that? Okay. I will tell you something I've discovered is sometimes if you have a phone next to the computer, is sometimes you will get some things. And I was just checking to see if my phone was close by. I keep the phone in case Aiden or somebody needs to let me know something is going wrong that I'm not seeing anything there. All right, I basically pushed it back in there too. I got one cord that I may need to replace. It seems to do there. But anyway, so sympathomimetics, carvedilol is a sympatholytic. It blocks it. So sympathomimetics, think about this, drugs that, where over-the-counter drugs that you see that may cause this would be cough cold preparations, decongestants, nasal decongestants, things that, make your eyes, these things that clear your eyes with that. So one of the things is any sympathomimetic, which typically, whether they're over the counter, a lot of the cough, cold, decongestants are the things. And if you use these with L-DOPA, sometimes what you can get is hypertension. So we have to be careful with that. We have to make sure that the patients know to avoid those type of things. Now, what we also see is that, again, what we're seeing is that even though we're using the L-DOPA to basically take care of some of the movement disorders of Parkinsonism, we can sometimes develop some dyskinesias, movement disorders that are drug-induced. This typically happens over chronic therapy. Some people think that what's happening is that you're getting a denervation change or a change with this constant stimulation. So also you're going to see the disease progressing. So even though it's drug-induced, sometimes some of the things we see may be loss of therapy. So what we see is that people on a large percentage will develop some sort of dyskinesia. It's estimated as much as 80%. The specific dyskinesia varies between the patient, but it's each patient, the patient that develops this dyskinesia, it's pretty consistent. A lot of things is some twisting and grimacing of the face or some weird movements of the distal extremities. That tends to see what is the most common presentation, and that's dose related. So one of the things that we may do is we may drop the dose down to see if that abates a little bit. Big thing about L-DOPA is, again, as you would imagine, we're changing dopamine levels. And here's the thing to remember. The basal ganglia is where we're targeting. That's where the neurodegeneration is occurring. But remember that other areas of the brain, especially when we're treating, using antipsychotics, is due to excessive, basically a hyperdopaminergia. So one of the things we have to remember is when we're giving drugs that may elevate dopamine levels, they may produce some particular type of things, and behavioral effects. So we have to be careful with these. Depression occurs. Of course, depression can occur even without L-DOPA because of the disease, just realizing they have this disease. But we see depression, we see anxiety, agitation. Agitation is a part of the disease as it progresses on, but the L-DOPA can sometimes can cause that. People may have difficulty sleeping. On the other hand, they may be very somnolent, very sort of out of it. Delusions, hallucinations, nightmares, confusion, and some people even experience euphoria. One of my friends who passed away a few years ago that had Parkinsonism, as his disease progressed, one of the big things was he started seeing hallucinations. He was on L-DOPA, he was on Cinemet, but he and his wife were flying over to Greece to actually see a former postdoc of his. They were sort of taking a vacation, and so they were flying it. He started hallucinating on the plane, and he was telling me that he was hallucinating that the plane was actually, this is while they were over the Atlantic, he was hallucinating that the plane was actually flying underwater. How he kept it together, I don't know. I thought he was going to tell me, or that he and his wife were going to tell me that, he started getting that he potentially got really agitated because he thought he was going to drown, but he didn't. He just said it was like, the plane was just like it was flying just underneath the water. And he said, and as his disease progressed and also with the drugs, he started developing probably about 6 months before he finally passed. he actually had developed a lot of agitation associated with it. So we see that there's a lot of behavioral effects that may be associated with L-DOPA. We also see that there's a lot of behavioral effects that's going to occur with the disease. These behavioral effects typically are going to be more frequent when the patient is taking the both the L-DOPA and the carbidopa. One of the other things we see is sometimes if they get ill, that this behavioral effects may be precipitated there. And what you're going to do is that we may have to use atypical antipsychotics. Now, when you're doing that, realize that when you're using the atypical antipsychotics, you're going to be blocking dopamine receptors. So sometimes the atypical antipsychotics, it's going to be a balance between what dose you can affect. I'm sorry, I just jumped because I just had a large hawk fly into my window right in front of me. One of the hawks is, I've got a pair of hawks that are outside. So that was a little startling there. But you've got to make a, you've got to make a decision, a benefit risk situation here when looking at the behavioral effects. Is that, how much is it going to worsen the condition, how much it improves it. And you may have to be careful in choosing the drug so that you have a drug with low activity on the dopaminergic component. We do see over time that there is fluctuations in response. This tends to occur the longer they're on it. Sometimes we see it's associated with when they're actually taking the levodopa. So we have what is called a wearing off reaction, that what happens is that if they take it earlier in the day, we may see that later on in the day, the L-DOPA seems to be wearing off. We see sometimes what is called end of dose akinesia. So it's as the dose drops or as it wears off, we may get that. So those are related to the timing, and sometimes you may have to adjust the timing so you get the best coverage. The other thing we have is something called on-off phenomena. There are periods where they call them the off periods, where that you have marked akinesia, so the drug doesn't seem to be wearing, and then you get the periods of on when you seem to have some benefit, but they still have some marked dyskinesia. That tends to occur over a few hours, and interestingly, that is the scenario with regard to that. What happens is that occurs when people initially responded well. That's one of the things that's sort of scary, is sometimes people seem to respond well, and then all of a sudden they start experiencing this. Gupta, there is some, I just saw an article, and I have not read that, that is talking about that the gut motility, not gut motility, the function of the gut basically deals with some of the bacteria and the probiotics and so forth, that there may be a relationship. And so I've seen a couple of those papers. I have not read that, but I will look at it and see if I can look up into that. And if I find anything, I'll post it for you. So I may try to look at that up when we take your next break, which is not going to be too awful long here. Yeah, Aiden, we'll probably in about 7 or 8 minutes, let's plan on giving the next test, okay? So I'm going to finish sort of the levodopa, and then we'll give the last 4 questions. So one of the things that we can see sometimes is that mydriasis can occur, so you can get pupil dilation. We have to be concerned with regard to that, because if they have acute glaucoma, it may actually precipitate it. We do see L-DOPA has been able to, or does interfere with some of the blood forming elements, so we get some blood dyscrasias. We can get precipitation of gout. People have complained. Eddie, we're probably not going to get to the antibiotics, so you'll have the slides, but I'm not going to test you on them, okay? So I don't see that we will be able to get to those. What I would suggest that when you're looking at on the antibiotic slides, if you would just glance over them, that there's some things in red with the antibiotics that talk about drug metabolism and CNS things. that may come into play, and I'll try to bring those out in the advanced pharmacology where that comes into play. Another thing that people get is they get discoloration of the saliva, urine, and vaginal secretions. It becomes brown, and the reason that is basically that the catecholamines that are formed can get oxidized or get changed by exposure to oxygen. And we can have some instances where priapism occurs, which is a prolonged erection. Many of the people with Parkinsonisms will develop erectile dysfunction. For a long time, there was this thing about, because we knew that sort of tolerance developed, or there was this hypersensitivity, there was a long time that that people were advocating what we call drug holidays, which means that they would stop the drug or step away from the drug. And these drug holidays would be 3 days, for example, over a weekend, or maybe even up to 3 weeks. And so the idea was it would sort of allow the body to reset. And the idea would be that you would, that the neurological and some of the behavioral side effects would sort of abate. What we've seen is that the benefit really is so short-term and the risk really outweigh it. There's a minimal effect on this on-off phenomena. But the biggest thing comes down to these last things that we see here from a standpoint of risk. One of the things is aspiration pneumonia. That's a big concern with individuals with Parkinsonism. There's a higher incidence of thrombosis or pulmonary embolism when they go on these drug holidays. Depression is big. And when they go on the holidays, the Parkinsonism may be so severe, they're almost immobile. So because of the risk associated with it and the minimal benefits, it's no longer recommended. You may still see a clinician every now and then that still thinks it's beneficial, but in general, most people do not recommend this. Another thing we've seen that sometimes with vitamin B6, people that are taking B6, that it may actually enhance the metabolism, and that can actually maybe preventing the therapeutic effect. So if we are using carbidopa or Cinemet, we don't have to worry about it, but using L-dopa alone, that can decrease its activity there. Kara, thank you for putting those articles up. I appreciate that. We don't want to give levodopa to patients on monoamine oxidase A inhibitors or 2 weeks after the discontinuation, because we can get hypertension. The reason we use 2 weeks is because monoamine oxidase inhibitors, typically everybody says 2 weeks, before when you use them and are using certain other drugs. It takes approximately 10 to 14 days to regenerate monoamine oxidase inhibitors. So monoamine oxidase. So basically that is what the why the basis for the 2 weeks is. Contraindications if you've got a psychotic patient, mainly because the L-dopa can precipitate or exacerbate the psychosis. Angle closure glaucoma, because it can make it worse and cause severe damage. We have to be careful with patients with peptic ulcers, because that can aggravate the disease. And also, we don't like to use it in patients with history of melanoma, because actually L-dopa is a precursor of skin melanin. All right, so this is a good place to stop. And I can't remember off the top of my head, there is a chance you may have a question or two on the on these 4 questions that may have a dopamine agonist. Just use your best choice on those. I know there's some questions in the post-test at the end of the day. So let's take this. Let's give you about 10 minutes for the quiz. 40. Let's come back at 5 minutes till the hour. Okay. And I'm checking real quick to see if. Yeah, question number 4, just take your best guess at it, okay? So we'll come back at 5 to the hour. I'll go over the questions and we'll continue on this. Quiz for you real quick, and Aiden, just leave it up here and I'll go from it. So question 1 is the preferred, the preferred treatment for diabetes insipidus is, and the correct answer is actually desmopressin. Diabetes insipidus is not insulin independent. Danazol is used for endometriosis, and desmopressin is the drug that's preferred over vasopressin. All right, so be careful from a standpoint of when you see diabetes, people immediately think about insulin, and this is due to the vasopressin issue, okay, deficiency. Okay, question number 2, human chorionic gonadotropin can be used instead of, and the correct answer is luteinizing hormone, which would be D. The human chorionic gonadotropin is very similar structurally to LH, and so it works perfect from that, from there. Question number 3, L-DOPA is converted to which substance in the basal ganglia? This is dopamine. So we've just finished talking about it. Pretty straightforward. The L-DOPA can, in some areas of the brain, may be converted to norepinephrine, but basically what we're looking for is the basal ganglia. And then 4, basically what we're looking at is, this one we have not covered yet. So the bottom line is, we will cover that in just a minute, but it is, and you actually split it in half with regard to it, but just to show you something here, and let me just move it here. So if we go to a couple of slides, I mean, a few slides up, basically what we use, it's a selective monoamine oxidase B type, which is specific for dopamine, whereas monoamine oxidase A does serotonin and norepinephrine. Okay, so again, we hadn't covered that, so you know, it's the class split 50-50, so that's not too bad. Okay. All right, so let's continue, and what we're going to try to do is we'll get these slides covered, and we're going to move to the next thing, which is, so the question is based, the answer to that is monoamine oxidase B. All right, which is B. Okay. All right, so let's move. So we've used L-DOPA, or we can use L-DOPA. So what's the other way we can elevate dopamine levels in the basal ganglia? And this would be using dopamine agonist, using drugs. So we know dopamine, we can't use dopamine because we can't get it to the basal ganglia if we administer it peripherally. We're going to have to basically, you know, we got to deal with getting it across the blood-brain barrier. So the advantage of using a straight dopamine agonist is, one, we don't have to require a conversion to an active metabolite. L-DOPA has to be converted to dopamine. There is no potential toxic metabolites with these current drugs that we use. They're not going to compete with other substances, so we're not going to have to use, you know, carbidopa, and we do have some that'll go across the blood-brain barrier, and that we may have some degree of receptor selectivity that can avoid some of the side effects, just depending on the drug. What we see with the dopamine agonist is that in general, there's no evidence that one agent is actually better than the other. What we do see is that sometimes, for whatever reason, a patient may respond better to one drug versus the other. Sometimes it may be the side effects that they see. Sometimes it may be in that person, their just system may be more sensitive to one drug over the other. Let me get you guys back to, realized I had dropped the chat off here, okay? All right, so come on, computer. All right, so we do see these, you know, L-DOPA is used quite a bit, but we do see that these DOPA agonists have been actually moved more to the first line agents. We still see, like I said, a lot of L-DOPA used, a lot of Cinemet used, but we've seen these drugs being moved more to the first line because of their advantages. One of the big things we see is a lower incidence of side effects compared to L-DOPA. We don't see as many response fluctuations as we saw with L-DOPA, and the dyskinesias seem to be not as bad as that. Sometimes what we've done is people are being treated successfully with L-DOPA, but they're getting that end of dose akinesia, so that the L-DOPA is sort of wearing off, or they're having this on-off phenomena. So what they've seen is, or what they've done is, sometimes they will add a dopamine agonist to them, to their regimen, and that seems to take care or help with this end of dose akinesia. So it's tweaking the L-DOPA somewhat. So the ones that we have, we see bromocriptine. It's primarily a dopa-2 agonist, dopamine 2 antagonist, excuse me, agonist. Pergolide is hits both dopamine and dopamine 2 agonist. Pramipexole is considered a dopamine 3 agonist, but it can hit some of the other dopamine 1 and 2 at higher doses. And then ropinirole is a dopamine 2. And again, from what we know, is apparently the dopamine 2 seems to be the most important for the receptor, but we just have to, but probably we need the D1 for maximal effect. So let's start with pergolide. It tends to be a little bit more effective than bromocriptine. We do see that it reduces the symptoms of Parkinsonism, and what we see is those people that are having those on-off fluctuations. What we actually see is with the pergolide, they tend to be more in the on period with these fluctuators versus being on the off period. One of the things that this does do is sometimes by lowering the dose of L-DOPA and then using pergolide, we get a less side effects, so we can use a combination therapy there. Pramipexole is sort of an interesting drug because one of the things we've discovered with Parkinsonism has been that, yes, we have degeneration of the basal ganglia and the dopaminergic neurons. And one of the things that we've seen is that there apparently is free radicals that may account for the damage. And one of the free radicals, which has been identified, is hydrogen peroxide. So pramipexole, it's not an ergo derivative, which means we don't have to worry about the vasoconstriction. But by scavenging the hydrogen peroxide, and if you look back here, pramipexole is really a D3 agonist, so it probably has not a whole lot of D2 agonism, but it seems to be a little bit different. It's still a dopamine agonist, but probably it may be this scavenging of this hydrogen peroxide that makes it effective. It's primarily used for mild Parkinsonism, and so there's somewhat of a limitation there. Ropinirole has been used, and this is one that will also smooth the response of L-DOPA, so you see it used here. But it does get metabolized through 1A2, so there may be potential drug interactions with regard to this. By the way, does anybody know what the ropinirole was originally approved for? It was a condition which some people it seems like there is it was originally approved for, you guys may have heard it, and some people think that there was a that this is one of the drugs that the drug companies basically had put in for invented a disease for, and this was what it was originally approved for. Was used for Parkinsonism, but one of the things that came for was restless leg syndrome. And there's people that have argued out that there is no such thing as restless leg syndrome. There are people that have restless leg syndrome or the conditions of it, and they say it's real. So, but a lot of people were arguing that this was that the drug companies made up a disease to market this drug. Let's see, here we go. So the side effects we see, a lot of these are GI. We see some anorexia, nausea, vomiting, constipation, some indigestion. Generally, those are manageable. There are a few patients that would be difficult, that this just is not going to be, they won't take it or discontinue it. But when they look at what they're looking at, with the signs and symptoms of Parkinsonism, most of them would do it. The biggest thing we worry about is especially older people, we're going to tell them about being careful about postural hypotension. Postural hypotension is also going to be a little bit more significant in a Parkinson's patient because they're having trouble moving anyway, and they're more susceptible to falls. So this postural hypotension is a concern. If these drugs are ergo derivatives, then we can get vasospasm. The hands start hurting. We see some The hands may turn real white, may be painful. And we do get some peripheral edema that occurs, which can be bothersome, but probably the postural hypotension. We can see some dyskinesias. They do not appear to be as bad as what we saw with the, with L-DOPA. But again, these drugs are getting into the brain, and so we may see some confusion. We may see hallucinations, delusions, and some of these CNS effects may actually be worse with these dopamine agonists. Typically, it's reversible, so by lowering the dose or taking them off the drug, it can reverse it. It's something we have to watch for. Other things we see is some patients will complain of nasal congestion, and one of the things that we see is what is called erythromelalgia. And what that is, the erythro stands for redness, so people get these painful red swollen feet and hands, and that can be pretty bothersome. We also see, specifically with pramipexole and ropinirole, that people have fallen asleep at inappropriate times, and that can be sort of one of the deal breakers as to whether we use those or not. But with any of these drugs, always be aware that if there's been an increased dosage elevation recently, if there has been a potential drug interaction, drug added or taken away, which could affect this, and you start seeing these side effects, those, when you start seeing those, again, some of these things can occur with the progression of the disease, but typically as they progress, it occurs with the disease progression, it occurs more gradual, where with the drug, it would occur more abrupt. But you might have to make that decision and do a rule out of whether it was these behavioral effects are due to the disease progression or due to the drug. They're pretty much contraindicated if a person has a history of psychotic disease, because basically you're going to be stimulating that. And if people have a peripheral vascular disease, then you're going to avoid the ergo derivatives. I'm not going to ask you to differentiate between which ones are ergo or not. Again, it's just a concern there. Now, another way we've done, so the dopamine agonist would be direct stimulation of the dopamine receptors, and we've got a hypodopaminergia, so we can stimulate it. One of the things that we may see is, as the degeneration occurs, there's going to be less dopamine receptors. The body may try to basically upregulate the dopamine receptors, but one of the problems is as that area deteriorates, you may have a limitation. Now, another thing we can do is we can try to elevate the dopamine that's there. And we can use monoamine oxidase, MAO inhibitors. So as I said a moment ago, we have two types of monoamine oxidase. We have type A. That one is the one that is metabolizing norepinephrine, serotonin. Type B is the one that metabolizes dopamine. So what we want to do is we want to target the type B so that we can elevate the dopamine levels. So the drug that we see that is selective for monoamine oxidase B, and again, selectivity is going to be a function of dose, but one of the things we see is that selegiline is the drug that is a monoamine oxidase B inhibitor. So by inhibiting monoamine oxidase B, it decreases the breakdown of dopamine. We see that using this on-off or wearing-off phenomena can be reduced somewhat. And typically what we see this use, selegiline is going to be given to people that are on L-DOPA that seems to be having a declining response to the L-DOPA. So it's going to be given later on in therapy. If they give it later in the day, we typically want to give it earlier in the morning, because we can see that they may have difficulty sleeping if it's given late in the day. We don't want to use this drug with meperidine, tricyclic antidepressants, or SSRIs, because even though it's selective for monoamine oxidase B, there's a chance that it could elevate serotonin levels at particular doses. We can see sometimes an increase in the side effects of L-DOPA, because what you're doing is L-DOPA is increasing dopamine, which may be we're looking at the side effects associated with that, and then you're putting in to further increase that. So pretty ineffective used as monotherapy. Biggest thing is that we don't want to see this used when a non-specific monoamine oxidase inhibitor is given, what happens is that you get a big elevation, especially of norepinephrine, and that can cause a hypertensive crisis. Najib, a good point there is that we do see that mouth sores can occur. That's true. The COMT inhibitors, this is something we don't see, we haven't seen a lot of. We've seen monoamine oxidase inhibitors, but people sort of ignored the catecholomethyltransferase. Got a couple of drugs that inhibit catecholomethyltransferase, which is the other enzyme that metabolizes catecholamines. So we have inacapone and tolcapone. And so what we find is when we inhibit dopa decarboxylase, what we get is a activation of catecholomethyltransferase. So we see increases in plasma levels of the 3-O-methyl-dopa. And what 3-O-methyl-dopa does is basically competes with the L-dopa. And so we get a very poor therapeutic response there. So one of the things that we see is with the COMT inhibitors is they prevent the accumulation. So the COMT inhibitors do not produce the 3-O-methyl-dopa. The 3-O-methyl-dopa occurs with the production of the L-dopa. So what happens is as the 3-oxidative methyl-dopa builds up, that basically inhibits the L-dopa. So what you do is you give the CO2 inhibitors, and what that does is it prevents the accumulation because the O-methylation is not occurring by inhibiting the COM2. So what the COM2 inhibitors do is basically prolong the effect of L-dopa. And that allows you to reduce the dosage, the fluctuations that occur that can minimize it. And inacapone is the one that's preferred because the other drug, tolcapone, basically can produce some hepatotoxicity. So the entacapone is one of these things where that these drugs are not used so often. They got short half-lives, multiple doses. If the person is going to be taking tolcapone, they have to actually sign a waiver or not a waiver, they have to sign a consent form that basically says that they're going to get liver monitoring every 2 weeks for the first year. Then we start dropping it down. So one of the problems is that compliance is a real issue here. Many of these people, if they're on L-dopa and their disease has progressed, they're not going to be able to drive. So somebody's got to bring them in to do liver function test every 2 weeks. So again, the short half-lives requiring multiple daily doses, the liver monitoring just basically create a problem. Another drug is amantadine. Basically, we're not quite sure of its mechanism of action. We think that it may potentially affect dopamine function by somehow affecting synthesis, release, or reuptake. This drug, in theory, when it came out, people still try to use it. It's not as potent as L-dopa. One of the big problems is that after a few weeks, it may be completely ineffective. So some patients, we have a little bit of success with this when other things have failed, but generally, in most patients, it's not a good option. So with amantadine, we have a lot of CNS effects. They're reversible, but we get a lot of restlessness, depression, irritability, can't sleep, agitated, hallucinations, can get some acute psychosis. We also have some dermatological effects. One is called livedo reticularis, which is sort of some liver-colored liver discolorations that occur on the skin. But it's a pretty, a lot of things that occur with amantadine. For the side effects and the short-lived benefit, it really comes down to whether the benefits outweigh the risk on it. We do get a lot of peripheral edema. We can use diuretics to help that. Postural hypotension, again, is another issue. But we have to be careful specifically with patients with seizures or heart failure. So again, a lot of issues associated with amantadine, which just don't make it a good drug for us to use. Now, another thing we talked about earlier on, we talked about the Parkinsonism, is that although we can affect the dopamine, dopamine agonist, we can give L-DOPA, we can use enzyme inhibitors to elevate the DOPA. But another thing is we have a cholinergic, dopaminergic sort of interface there. And so as the dopamine levels go down, one of the things that may happen, you get an imbalance between the cholinergic system and the dopaminergic system. So one of the things that has been used is to use antimuscarinic action. So what you're doing is, since the dopaminergic actions are going down, let's reduce the cholinergic actions to sort of keep the balance. So what we find is that there's a lot of antimuscarinic drugs, benztropine, piperidine, orphanedrine, procyclidine, trihexylphenyldyl. All of these their main mechanism is anticholinergic, and what you're doing is trying to make, as the dopaminergic system goes down, is to keep the cholinergic system in balance. What we have seen is that these drugs don't affect bradykinesia very much, so there's not a lot of effect there, but they do show some improvement of tremor or the rigidity associated with it. So in that instance, they may help. One drug may not work as well, or it may fail, but another drug may work. So sometimes there's trial and error. We see anticholinergic side effects. We see drowsiness, mental slowness, restlessness, confusion, many of the things that we see, including mood changes that can occur. So we have a lot of CNS side effects that can potentially emerge. The typical cholinergic signs that you should know by heart by now: dryness of mouth, blurred vision, mydriasis, the pupils dilate, tachycardia, urinary retention. So if they don't work, or we're going to change drugs, one of the things we need to do is slowly withdraw those drugs, because if we just stop them automatically, we can get a very acute, severe exacerbation of the Parkinsonian symptoms there. Want to be careful. Any other drugs that may have antimuscarinic properties, other antidepressants like tricyclics, antihistamines, got to be careful there, because we can get excessive anticholinergic actions. So there's our options that we have, is that basically we can elevate dopamine, or we can elevate the dopamine by giving a precursor. We can elevate dopamine by inhibiting its metabolism, or increasing its release and inhibiting its metabolism. We can directly stimulate dopaminergic receptors by giving pure agonists, and we can try to keep the dopaminergic cholinergic systems in balance by using antimuscarinics to offset the cholinergic that becomes more dominant. So those are all things that can occur there. Now, let me point out, because it's just as important when you're dealing with treatment of Parkinsonism, it's just as important for you to recognize what drugs can actually cause these Parkinsonism or the Parkinsonian effects. Drugs that deplete dopamine, that produces a hypodopaminergic. Reserpine is a drug, tetrabenazine. Those drugs have very, very little usage. We still see a few people use them. They basically, remember we talked about reserpine being used as an antihypertensive drug, but its prominence as an antihypertensive drug has dropped quite a bit. Probably our biggest thing is dopamine antagonists. Any of the phenothiazines, haloperidol. Keep in mind any of the atypical, the newer drugs, they could do that. So what we typically are going to see is that when these drugs do produce this dopamine depletion or blockade of dopamine, that's usually going to occur within the first 3 months of treatment, typically. Most of the times these are reversible, and what we typically will do is, although we're withdrawing the drug, we will probably use an antimuscarinic. The other drugs, designer drugs, which include a lot of street drugs. MPTP is actually a derivative of meperidine, but sometimes when people are making ecstasy or some of these club drugs, if they are not careful with their chemistry, they can get these analogs or derivatives of some of these methamphetamines and ecstasy type drugs, that basically those can attack the basal ganglia and cause Parkinsonism. Sometimes it's reversible and sometimes it's not. Now, there's a lot of other movement disorders. We're going to just cover these pretty quickly because these can be um, can affect quality of life. We have physiological, what we call postural tremors. This is a normal effect. People tend, when they get anxious, when they get very tired, beta agonist, for example, people that are taking beta agonist for pulmonary, sometimes systemic absorption. And so what they will get is a tremor. Sometimes these can be treated with propranolol. One of the questions comes into play is that, especially if it's a beta agonist, one of the things do you really want to treat it with propranolol, or do you just want to reduce the beta agonist and maybe potentially find another drug? But things that can produce these tremors, bronchodilators, they acting primarily on beta 2, valproate, tricyclics, lithium, they can actually produce tremors that are dose dependent that can actually worsen this postural tremor. So if you think about it, when you get really, really tired to the point where you're just trembling, that's physiological postural tremor. So it's a normal phenomenon. We don't try to treat it. Our biggest concern is that other drugs may actually exacerbate it. Typically, we don't treat it if it is excessive in affecting it. We may use something like propranolol. The essential tremor, what we find is this is also tremor very similar to a physiological tremor we just talked about. This one will respond to a beta 1 antagonist, so we can use something like metoprolol. It'll also respond to a mixed drug like propranolol, and a lot of times propranolol may be used for this. One of the big things is how much is it actually interfering with the person? Do you want to really add another drug on there that may have its own side effects? For example, a beta 1 antagonist, we're going to worry about heart rate and blood pressure dropping. Can the person tolerate that? The other thing we see is what is called an intention tremor, and these occur not at rest, but they occur during movement. So when people intentionally start moving, we start to see the tremor sort of develop. Sometimes this is a toxic effect. Alcohol is a good example. Phenytoin, which is an anti-seizure medication, can actually produce this at high dosages. We don't really treat this. We just withdraw the offending drug. So again, sometimes we not, for example, with phenytoin, we may need to choose a different drug if this interrupts or causes too many problems. One of the things also to be aware of is a lot of times with tremors, if you see tremors and you see lithium, you might want to see if the lithium is by potentially causing that tremor. Huntington's disease, here we get the progressive chorea and dementia. Typically, it's going to emerge in adulthood. And we do know this gets back to these basic, this basic dopaminergic imbalance. So up in the basal ganglia. So we in Huntington's chorea, we see that there is dopaminergic, acetylcholinergic, GABAergic, potentially some other transmitters that are in it that have gotten into imbalance. What we typically see is an overactivity of the dopaminergic nigrostriatal pathway. And that may be sometimes because the postsynaptic dopamine receptors have become super sensitive. Sometimes that can occur as a result of dopaminergic depletion. And so sometimes what we can see is there may be a deficiency of one of these transmitters that normally antagonizes the dopamine. So in one sense, you're almost seeing a hyperdopaminergic response. So what we do know is we've seen some observational things. We see dopamine seems to either be hypersensitive. We see the GABA, which is an inhibitory, and glutamate, glutamic acid decarboxylase, which is involved with GABA synthesis, may be reduced, which means you've got an imbalance between GABA and dopamine. We see that the cholinergic choline acetyltransferase, which forms acetylcholine, is decreased. So we have a decrease in acetylcholine. And so we've got multiple things going. And what we've seen as far as therapeutically is the best approach is probably to antagonize or interfere with dopamine. So we can use reserpine, phenothiazines, or some butyrophenones. These are all drugs that interfere with dopamine activity. We also see that there may be drug-induced dyskinesias. We talked about it with L-DOPA. These can sometimes be precipitated by phenothiazines, which are the old conventional antipsychotics. We're going to go over a lot of these movement disorders as side effects when we talk about the antipsychotics. So we will probably spend at least an hour or so talking about these things and revisiting. So these drug-induced dyskinesias, we typically are going to see antimuscarinics used. And again, that's decreasing the cholinergic aspect to get it more in balance, because the phenothiazines are typically going to be blocking dopaminergic. We can use Benadryl, diphenhydramine, which can have antimuscarinic actions. We can also use diazepam. Of the three, diazepam is not our best choice. One of the concerns with diazepam is going to be the sedative effects. Even with diphenhydramine, we may see some sedation. But diazepam, we also have to worry about too much use and addiction and things like that. Now, one big disease that we have that is sort of the bane of the antipsychotics now, even the new drugs, the atypical antipsychotics, have been shown to potentially produce tardive dyskinesia. So anytime we have chronic neuroleptic theory and therapy, we're usually referring to that as using dopamine antagonists. So sort of what's interesting is the dopaminergic antagonists basically produce a hypodopaminergic state. And we need to watch it. And one of the big things we try to do is not to keep people on these or limit their use of these when we can. Of course, some people we can't. And what's been fortunate is that the new drugs tend to produce this less often, have a lower propensity to do it, but they still can do it. But when it started developing, one of the things that would happen is they reduced the dose. And sometimes that actually made it worse, while increasing the dose actually may suppress it. So it's difficult to treat. What we typically have seen in the past is we've used drugs that deplete dopamine, which is like reserpine, or we use dopamine antagonists. And what happens, though, is you get into this spiral where that you block it, and then you have to increase the dose to keep the main effect on. And so you get to the spiral, and it just, it's very difficult to manage. And truthfully, it's been tardive dyskinesia. Our best choice was try to prevent it rather than treat it, because the treatment was extremely variable as far as success. Many times it's irreversible. And so for a long time, we really didn't have any satisfactory treatment. And what we did see is that we try to avoid antimuscarinics, because when we're using these dopamine antagonists, because it increased the likelihood of developing tardive dyskinesia. But then in 2017, we had a drug called valbenazine, which was the first drug that was actually approved to treat adults that develop tardive dyskinesia. So what valbenazine does, it actually binds to the vesicular monoamine transporter 2. We refer to that as VMAT2. And that transporter transports the monoamines from the cytoplasm into the vesicle. So this drug seems to be somewhat effective with treating tardive dyskinesia, which has been a nice thing that we've now got a drug that at least has some success with it. The downside of this is basically it can be very sedating to the people. They can become very somnolent. But the other thing is it can prolong the QT interval. And prolongation of the QT interval, one of the problems here is that by prolonging the QT interval, you may set up for torsades. So you need to monitor for QT interval prolongation, so that monitor the EKG. We also see that CYP3A4 inducers or inhibitors and 2D6 inhibitors can produce a drug interaction. So we have to be careful for that. And those drug interactions could potentially make the QT prolongation more of an issue. We have a number of spasticity diseases. Basically, a lot of these are associated with cerebral palsy, multiple sclerosis, sequelae associated with stroke. There's a lot of different mechanisms. You don't need to know what these mechanisms are. I put this in, actually, I think we included these slides when we were talking about the pathophysiology. But we have a number of drugs we refer to as spasmolytics. Diazepam and some of the other benzodiazepines have been used. You have to use sort of high doses of these. Baclofen, tizanidine, gabapentin, that should be dantrolene with an R in it, and even botulinum toxin have been suggested. So diazepam works pretty much in all the patients with all forms of spasm. What it does is it actually facilitates GABA at the spinal cord. Biggest problem is sedation, and long term, you got to worry about potentially addiction. Baclofen is also acting at the GABA receptor. It pretty much activates the GABA B receptors. So what it does is it hyperpolarizes the neurons and then also decreases calcium influx. So by hyperpolarizing it, the muscle cells are not as responsive, and then the reduction in calcium, less contraction that can occur. Another thing is these muscle spasms can be very painful, and we do know that substance P is involved in pain, and that by inhibiting the release of substance P, that can reduce the pain. The thing about baclofen is that it works as well as diazepam. It's less sedating, so it's works pretty well. So it's sort of preferred. We may see diazepam used sometimes for the first relief, then move them to baclofen. Tizanidine actually is a structure. It's very similar, related to clonidine, and what this does is it acts in the cord, and it inhibits the pain response or transmission in the spinal cord. Works pretty well with, it's about the same as baclofen or diazepam, and we do get some drowsiness, dry mouth, and some asthenia. So if the patient's, basically you're seeing baclofen and tizanidine. Gabapentin has shown some promise in MS, but not as effective as the other drugs. And dantrolene is very similar to phenytoin. And what it does is it interferes with calcium. By interfering with the calcium, it prevents the muscles from contracting. We see it used a lot for malignant hyperthermia because the muscles contract and that increases temperature. And by relaxing those, it alleviates it. But there are some significant side effects with dantrolene. And then botulinum toxin has occasionally been used, but probably baclofen is probably one of the preferred drugs, or diazepam for short term. Okay, so we're not even going to go into the antibiotic. You can look over the antibiotics. You will not be tested on the antibiotic drugs. I'll try to have the test up on Tuesday. And so now what we'll do is that we'll let Aiden put up the post-test. If you guys looking over this material have any questions, send me an email. Even with the antibiotics, if you look over it and have a question, send that to me. But I will not include any test on the exam about the antibiotics. Okay. I think that the exam has to be. The grades are due, from what Dr. Steinem told me. Is, I think, Aiden, you may know this. I remember this. I think it has to be by midnight on the 12th of May. So I will try to get the exam to Aiden by tomorrow so that it can be put up by Monday night or Tuesday. Okay?
That's true, doctor.
Okay, thank you, Aiden. But you guys have got another class under your belt. I will not see you for a little bit, but I'll see you, I think, in the fall. And I hope you have a good summer. And if you have any questions that come up, please don't hesitate to send me an email. Aiden, thank you very much for everything that you've done. And I'm going to turn it over to you to put up the post-exam. And you guys have a great rest of the day.
Post-test is already on the Moodle, doctor.
Thank you.
Awesome.